1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
Alpha, CFTR again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, when you think about the human lungs, it's so tempting to just imagine like a perfectly engineered set of bellows.
Right. You pull the handle, the air rushes in. You push it, the air rushes out.
Exactly. It's supposed to be effortless, completely invisible to our conscious minds. But imagine just for a second needing to consciously think about every single breath you take.
Every minute, every hour, every single day of your life.
Yeah, and for millions of people, that perfectly engineered bellows system is just fundamentally broken. So today, we're stepping into a highly specialized, really intensive deep dive into the world of obstructive lung diseases.
And we are not just doing some surface-level summary of symptoms here.
No, definitely not. We're stepping directly into the shoes of an elite ICU intensivist and a critical care nursing instructor. We're aggressively applying the 80-20 rule, or the Pareto principle, to our source material today.
Which means we are stripping away the fluff. We're focusing exclusively on the high-yield pathophysiology, that minute-by-minute bedside decision-making, and the critical nursing actions that actually save lives.
The stuff that prevents irreversible injury and, honestly, dominates exams. So, setting the landscape, we are covering 4 distinct but related heavy hitters today: bronchiectasis, cystic fibrosis, asthma, and CPD.
And all of them share one major hallmark, which is an increased resistance to airflow. The air just cannot flow freely.
Right. But what makes this so challenging for you at the bedside is that each of these 4 diseases kills patients in entirely different ways.
They really do. In the ICU, survival is never just about memorizing facts or checking off a list of symptoms. It's about understanding the cascade of failure.
Knowing exactly why it's happening.
Exactly. Tracing the problem from the initial cellular trigger all the way down to the clinical catastrophe playing out right there in the hospital bed.
So let's dive right in with our first condition, bronchiectasis. I always think of this one like an old overstretched water balloon that has completely lost its elastic snap.
That's a really great analogy, actually.
Right. Because instead of contracting and pushing the water out, or in this case, pushing mucus and bacteria out, the structure just sags. The fluid just pools at the bottom.
Creating this stagnant, infected swamp inside the airways. Bronchiectasis is defined by the permanent abnormal dilation of the medium-sized bronchi.
And because of that permanent structural ruin, the airway loses its mucociliary clearance.
Exactly. It affects over 500,000 people in the U.S., and we most often see it in adults who have a history of a severe, poorly treated lung infection.
Now, the trigger is that severe infection.
Right. The initial infection initiates an inflammatory response that is so severe, it essentially destroys the elastic and muscular structures that support the bronchial wall.
So the architecture of the airway is literally crumbling. And if the walls are destroyed, you lose that mucociliary escalator you mentioned.
Yeah, those tiny hair-like cilia that normally sweep debris up and out of our lungs are heavily damaged or just completely paralyzed.
Which leads to the decompensation. Because those cilia can't sweep the mucus upward, you get stasis.
Thick, heavy mucus just sitting in these newly formed floppy pockets. And this stagnant environment is the perfect breeding ground for bacteria.
Especially Pseudomonas, right?
Yes. Pseudomonas aeruginosa is a particularly common and aggressive invader here. And when the bacteria colonize this swamp, they attract an army of neutrophils.
And the neutrophils are trying to help, but they kind of make it worse.
Well, they attempt to fight the infection, but in doing so, they release destructive enzymes that cause even more chronic inflammation, massive edema, and further weakening of the walls.
It's just a vicious cycle, creating these deep pockets of purulent infection, which completely explains the bedside assessment.
Absolutely. The defining clinical sign is a persistent, relentless cough. And they aren't just coughing up a little clear phlegm.
No, the text described consistent production of thick, tenacious, highly purulent, foul-smelling sputum. We're talking cups of it a day sometimes.
The assessment of that sputum is crucial. You'll see that chronic productive cough, pleuritic chest pain from the constant coughing and clubbing of the fingers.
From the chronic hypoxia, right?
Exactly. But the truly dangerous finding, the one that requires immediate aggressive intervention, is massive hemoptysis, coughing up significant amounts of blood.
Okay, let's unpack that for a second. If the primary problem is a floppy airway filled with mucus and bacteria, where is all this massive bleeding coming from?
It comes down to how the body desperately tries to heal itself. The recurrent infections and chronic inflammation severely injure the local pulmonary blood vessels.
So the body tries to rebuild the plumbing.
Right. It undergoes a process called neovascularization. It literally grows new blood vessels, forming large connections originating directly from the bronchial arteries.
And those arteries are under high systemic pressure.
Very high pressure. But these new vessels are chaotic and incredibly fragile. Plus, they're constantly exposed to the ongoing swamp of inflammation and the violent mechanical shearing force of the patient's cough.
So they rupture easily. And when they do, it's not a slow ooze.
No, it can be a massive arterial pressure bleed straight into the airway.
Wow. Knowing that, the diagnostics make a lot of sense. A standard chest x-ray isn't going to show you that precise structural ruin.
Which is why the high-resolution CT scan is the absolute gold standard here. It lets us visualize the exact architectural dilation and those cystic spaces filled with mucus.
And physiologically, spirometry will show a classic obstructive pattern, meaning a decreased FEV1 and a decreased FEV1 to FEC ratio.
Because the airways are floppy, they prematurely collapse when the patient tries to forcefully exhale, so the air gets trapped.
So for the nursing process, ADPIE, the first assessment priority is distinguishing between a patient just dealing with their chronic baseline stasis versus someone in acute respiratory distress.
Right. The primary nursing diagnosis is impaired respiratory function, and our implementations heavily focus on airway clearance techniques, or ACTs, and aggressive hydration.
Ensuring like 2 to 3 liters of fluid intake daily, assuming their heart and kidneys can handle it, to liquefy those secretions.
Because if they get even mildly dehydrated, that mucus turns into absolute cement. The cilia can't move cement. Systemic hydration waters down the swamp.
But if things go wrong, we have to prioritize. What are the priority nursing actions? First, maintain a patent airway.
Next T, if they're desaturating below 90%, elevate the head of the bed to 30 degrees and apply low-flow oxygen.
Then, and this is the massive bedside rule, if you suspect active airway bleeding, you must immediately place them in a side-lying position with the bleeding side down.
Bleeding side down. It isolates the hemorrhage and preserves gas exchange in the good lung.
Because if the bleeding side is up, gravity just drains that high-pressure blood straight across the carina into the healthy lung.
Exactly. They would essentially drown in their own blood. It's a rapid, life-saving intervention.
Moving to medications, antibiotics are the mainstay. Usually a minimum of 14 days, tailored to whatever grows in the culture.
We also use bronchodilators to open the airways and hypertonic saline nebulizers.
Which is fascinating because the high salt concentration in the airway creates an osmotic gradient, literally drawing water out of the tissues to liquefy the mucus.
Exactly. And mechanically, we use chest physiotherapy, or CPT, with postural drainage.
Wait, let me push back on that. Is CPT always good? Because if I have a patient with those fragile neovascularized blood vessels, percussing their chest sounds like a terrible idea.
It is a terrible idea. CPT is absolutely contraindicated in the presence of active bleeding. You stop all percussion immediately.
Good to know. So for complications, we're constantly watching for pulmonary hypertension and massive hemoptysis. How do we know they're deteriorating?
The patient is getting worse if their work of breathing sharply increases, or if they expectorate a moderate to large amount of blood. A sudden shift from just a little spot of blood to a large volume indicates a major neovascular rupture.
And that means immediate escalation. Notify the provider right away and ensure there's a valid type and cross-match on file because they'll need a rapid transfusion.
So for pattern recognition, if you see a chronic productive cough, copious purulent sputum, and frequent recurrent pneumonias, think bronchiectasis.
Okay, so if I'm summarizing this for a handoff, if you remember only 5 things. 1, the core patho is permanent dilation and loss of elasticity.
2, the key assessment finding is copious purulent sputum.
3, the most dangerous complication is massive hemoptysis.
4, the priority nursing action is positioning them bleeding side down.
And 5, the most important treatment is prolonged antibiotics plus airway clearance techniques.
Our one-sentence clinical picture is a patient with a history of severe respiratory infections presenting with a daily relentless cough producing cups of foul-smelling sputum.
And the golden rule: if you see massive hemoptysis in a chronic cougher, think neovascular rupture and position them bleeding side down immediately.
Exactly. So that covers acquired structural failure. But what happens when that failure is written directly into the patient's DNA? That brings us to cystic fibrosis.
Yeah, transitioning from an acquired swamp to a genetic blueprint error that turns the body's secretions into glue. The text calls this a chloride channel catastrophe.
And it really is a systemic catastrophe. CF is an autosomal recessive genetic disorder caused by a mutated CFTR gene on chromosome 7.
Which means they have to inherit 2 copies of the defective gene, right?
Correct. The CFTR gene normally creates a protein channel that actively transports sodium and chloride ions across epithelial cells. When it's mutated, that transport is blocked.
Which dehydrates secretions all over the body. It destroys the lungs, the pancreas, the reproductive tract. Let's trace that pathophysiology.
The trigger is the defective CFTR channel. Because salt can't move, water doesn't follow.
So the mucus lining the passageways becomes completely dehydrated.
Right. It turns from a thin lubricating layer into a thick, sticky sludge. In the lungs, this sludge plugs up the bronchioles, leading to hyperinflation and scarring.
And in the pancreas, it plugs the exocrine ducts. So the digestive enzymes can't reach the intestines.
Instead, they back up and begin to auto-digest the pancreas. It forms these fibrotic cysts, which is where the name cystic fibrosis comes from.
And back in the lungs, when neutrophils rush in to fight infections and eventually die, they release concentrated DNA that makes the sputum even thicker, like a biological mortar.
It's an absolute nightmare at the cellular level. So clinically, early on in newborns, you might see meconium ileus because the first stool is so thick it causes a bowel obstruction.
And then as they grow, you see steatorrhea, those fatty, foul stools, because they can't digest fat. Plus failure to thrive, persistent cough, and famously salty skin.
Because the CFTR channel also works in the sweat glands, in CF it can't reabsorb sodium and chloride back into the body, so the skin is literally coated in electrolytes.
Which explains the diagnostics. The gold standard is the sweat chloride test. Values greater than 60 millimoles per liter confirm it.
For our ADPI assessment, we have to recognize that this patient is simultaneously nutritionally compromised and dealing with impaired respiratory function.
So are priority nursing actions. First, airway clearance via ACTs and bronchodilators. Next, aggressive IV antibiotics for exacerbations. Then, nutritional optimization.
For medications, we have a highly specialized inhaled drug called dornase alfa, or pulmozyme.
Oh, this is the one that targets the DNA mortar, right?
Exactly. It's a recombinant human enzyme that literally cleaves and degrades the extracellular DNA in the sputum.
Yeah.
It thins it out dramatically.
That is incredible. And for digestion, we use pancreolipase, but the timing on this is non-negotiable.
Absolutely non-negotiable. Pancreolipase must be taken immediately before every single meal and snack.
Because if they eat without it, they'll develop severe malabsorption or even a bowel obstruction.
Exactly. A huge ICU pearl. Never withhold pancreatic enzymes if the patient is eating. We also use CFTR modulators like ivacaftor, which actually target specific gene mutations to keep the channel open.
And for antibiotics like aerosolized cobramycin, it's important to note that CF patients metabolize drugs incredibly rapidly.
Yes, so they require prolonged, exceptionally high-dose therapy.
Fluid and electrolyte balance must be so tough too. They're a huge risk for severe salt depletion, especially during fever or intense aerobic exercise.
Which, by the way, aerobic exercise is highly recommended to help clear those airways. But yes, they need aggressive supplemental salt.
Let's look at complications. They can develop CF-related diabetes or CFRD because the pancreas destroys its own islet cells.
It has features of both type 1 and type 2 diabetes. They also develop cor pulmonale and are at risk for pneumothorax from surface blebs popping.
And how do we know they are deteriorating gastrointestinally?
The patient is getting worse if they develop severe right lower quadrant pain with a palpable mass and vomiting. This is distal intestinal obstruction syndrome, or DIOS.
So if you see DIOS, or acute respiratory insufficiency, or massive hemoptysis that requires immediate escalation, ICU admission, and maybe mechanical ventilation.
For pattern recognition, if you see a young patient with recurrent Pseudomonas pneumonias, new onset diabetes, statorrhea, and infertility, think cystic fibrosis.
So boiling it down to our 5 things for CF. 1. The CFTR mutation blocks sodium and chloride transport.
2. The key findings are incredibly sticky mucus, salty skin, and steatorrhea.
3. A major dangerous complication is DIOS, that bowel obstruction.
4. The priority action is administering pancreatic enzymes before all meals.
And 5, treatment relies on airway clearance, dornase alfa, and high-dose antibiotics.
Our one-sentence picture. A thin young patient with a chronic cough, barrel chest, and salty skin who requires bills just to digest their food.
And the rule: if you see ROQ, pain and vomiting in CF, think DIOS and aggressively manage it medically to prevent ischemic bowel.
Perfect. So we've covered the floppy airway and the glued airway. Let's shift to asthma, the hyperreactive airway.
Yeah, if the others are permanent damage, asthma is like an allergic panic attack where the airways just suddenly swell up and slam shut.
It's uniquely defined by its reversibility. It's an unpredictable course triggered by profound inflammation and bronchial hyperreactivity.
The triggers could be anything, right? Allergens, exercise, cold air, GERD, or even beta blockers and NSAIDs.
Exactly. And the pathophysiology happens in 2 phases. The early phase hits within minutes. The allergen cross-links with IgE antibodies on mast cells.
And mast cells act like cellular bombs.
Right. They degranulate, releasing a flood of histamine and leukotrienes. This causes vasodilation, intense mucosal edema, severe bronchospasm, and copious mucus production.
And then there's the late phase, which is super dangerous. That hits 4 to 6 hours later.
Yes. Those initial chemicals act as a homing beacon for eosinophils. When they arrive, they cause persistent inflammation. Over time, this leads to structural airway remodeling like fibrosis and smooth muscle hypertrophy.
So our bedside assessment. The classic signs are expiratory wheezing, a prolonged expiratory phase, chest tightness, and a cough. But let's talk about the silent chest.
This is critical. If a patient is wheezing violently and suddenly goes completely quiet, it is not a good sign.
It doesn't mean the albuterol worked.
No, it is an ominous sign of impending respiratory failure. It means the airway is so 100% obstructed, or they are so exhausted, that zero air is moving.
Terrifying. Diagnostically, we looked for reversibility on spirometry. A post-bronchodilator increase of greater than 200 milliliter than 12%. And we can use FeNO, fractional exhaled nitric oxide, to indicate eosinophilic inflammation.
For nursing ADPIE, assessment focuses on whether they can speak in sentences, phrases, or just single words.
And for implementation, you actively use the talking down technique. Calm voice, eye contact, coach them through pursed lip breathing.
Because exhaling against pursed lips creates positive back pressure, splinting the airways open so trapped air can escape.
So our priority actions. First, position in high Fowlers and apply O2 to keep SATs above 90%. Neg-ST, administer inhaled SABA, like albuterol. Then, systemic corticosteroids to halt that late-phase inflammation.
Let's talk meds. Inhaled corticosteroids, or ICS, are the first-line daily controller, but patients must rinse their mouth after use to prevent oral thrush.
And SABAs are the rescue inhaler. But what about LABAs, like Somaterol?
A LABA must never be used as monotherapy in asthma. It keeps the airway propped open, but has zero anti-inflammatory properties.
So the inflammation just burns unchecked until they have a massive, unrescuable attack.
Exactly. It's a huge safety trap. Now, looking at hemodynamics and ABGs during an attack.
Right. Early on, they hyperventilate, so PaSHA-2 drops and pH goes up. Respiratory alkalosis.
But as they fatigue and air trapping worsens, they can't blow off the CO2, so the PaSHA-2 normalizes and then starts to rise.
So a normalizing or rising CO2 in an asthma attack is a massive, screaming red flag. It means they're crashing into respiratory acidosis.
Which leads right into status asthmaticus, an attack unresponsive to standard treatment, leading to hypoxia and hypercapnia.
They're getting worse if they're confused, agitated, have a silent chest, or that CO2 crosses from low to high.
If that happens, you immediately call a rapid response. Prepare for intubation, mechanical ventilation, and give IV magnesium, which is a profound, smooth muscle relaxant. We also use ketamine or propofol for sedation.
And a quick differential, the asthma triad. If you see nasal polyps, asthma, and acute wheezing after taking ibuprofen or aspirin, think NSAID sensitivity.
So the intensive is thinking here. Problem is acute bronchospasm and edema. Failing physiology is air trapping and muscle fatigue. Immediate threat is status asthmaticus. Intervention is IV magnesium, intubation, steroids.
Reassessing with ABGs for clearing CO2 and listening for the return of breath sounds. Okay, our 5 things for asthma. 1. Reversible IgE-mediated bronchospasm.
2. Wheezing on exhalation.
3. Status asthmaticus and the silent chest.
4. Priority action is albuterol immediately, then systemic steroids.
And 5. ICS is the definitive controller.
The one-sentence picture. A patient leaning forward, speaking in single words with a hyper-expanded chest and high-pitched expiratory wheezes.
And the rule: if a previously wheezing patient suddenly goes quiet but is still struggling to breathe, Think silent chest and prepare to intubate immediately.
All right, finally, we arrive at the irreversible trap, COPD.
Yes, if asthma is a reversible panic attack, COPD is the slow, irreversible destruction of the lung's architecture, like a house slowly losing its load-bearing walls.
It's progressive and irreversible, combining chronic bronchitis and emphysema. Smoking is the #1 cause, though alpha-1 antitrypsin deficiency, or AATD, is the genetic cause.
So the trigger is smoke, or AATD, and physiologically, the oxidative stress increases proteases and inhibits the protective antiproteases.
Right, the natural balance is destroyed, the proteases run wild and literally digest the alveolar walls.
So the alveoli merge into these large floppy blebs and bullae, and a lung loses its elastic recoil. Air goes in, but it can't get out, causing massive hyperinflation.
And that chronic hypoxia triggers pulmonary vasoconstriction globally across the lungs.
Which means the right ventricle has to pump furiously against high pressure, leading to right-sided heart failure, or cor pulmonale.
Exactly. So on assessment, you see a barrel chest, tripod positioning, pursed lip breathing, and polycythemia, which is that bluish-red skin from excess red blood cells.
Plus the signs of right heart failure, jugular venous distension and profound pedal edema. Diagnostically, the FEV1-FVC ratio is less than 70%.
And their baseline ABG typically shows a fully or partially compensated respiratory acidosis. Low normal pH, high CO2, high bicarb.
For ADPIE, the key is distinguishing their chronic baseline from an acute exacerbation, which is a sudden change in dyspnea or sputum volume purulence.
Implementation focuses on breathing retraining, like diaphragmatic and pursed lip breathing and energy conservation.
Priority actions during an exacerbation. First, apply O2 via nasal cannula or BiPAP. Next T, administer SABA and LAMA bronchodilators. Then, teach huff coughing.
But let's bust a myth right now. You mentioned O2. Some people think you should never give O2 to COPD patients because it stops their hypoxic drive to breathe.
Right, I was taught that in school.
It is a dangerous myth. You never withhold life-saving O2 if they're hypoxic. We just target a specific range, usually 88 to 92% and2. Titrate carefully, but do not let them die of hypoxia.
Thank you for clearing that up. Medwise bronchodilators are first line. SABAs, LABAs, and LAMAs like tiotropium.
But unlike asthma, you never use an inhaled corticosteroid as monotherapy in COPD. It's only added for severe cases alongside a LABA or a LAMA. We also use roflumilast for severe chronic bronchitis.
And procedurally, lung volume reduction surgery, or LVRS. It sounds crazy to cut out 30% of a dying patient's lung.
But by removing that useless hyperinflated tissue, you allow the flattened diaphragm to return to its normal dome shape, restoring respiratory mechanics.
That's amazing. Now, nutrition is tough for them. High protein, moderate calorie fat. But a crucial nursing action is limiting liquids at mealtimes.
Yes, to prevent early satiety. Have them rest 30 minutes before eating and offer cold foods to make them feel less full.
So how do we know they're actively deteriorating?
They're getting worse if their baseline compensated respiratory acidosis tips into acute uncompensated acidosis. The pH falls, CO2 sharply rises, and they develop altered mentation or severe somnolence.
If they become overly sleepy, it's a huge red flag for CO2 narcosis. Escalation means rapid response and BiPAP, or prepare to intubate.
For differentials, if you see the barrel chest and smoker's cough plus distended neck veins and pedal edema, think cor pulmonale. And never use a non-selective beta blocker like propranolol. It will trigger bronchoconstriction.
So our final 5 things for COPD.
Right.
1. Irreversible alveolar destruction and loss of elastic recoil.
2. Barrel chest and pursed lip breathing.
3. Cor pulmonale, right heart failure.
4. Controlled O2 therapy targeting 88 to 92% and BiPAP for exacerbations.
And 5. Smoking cessation is the only way to actually slow progression.
The clinical picture. An older patient with a heavy smoking history, tripod positioning, pursed lip breathing, a barrel chest, and dependent edema.
And the rule, if you see sudden worsening of dyspnea and sputum volume purulence, think acute exacerbation and initiate bronchodilators, steroids, and BiPAP to prevent intubation.
That thoroughly covers all 4 obstructive mechanisms.
Yeah, so wrapping up this deep dive, I want to thank you, the listener, for sticking with us through this masterclass. We've mapped out exactly how the human respiratory bellows fail, from the floppy infected walls and bronchiectasis to the genetic glue of CF, the allergic panic of asthma, and the irreversible structural collapse of COPD.
But before we go, the source text leaves us with a really provocative thought. Normal, healthy aging actually causes the lungs to lose elastic recoil and the chest wall to stiffen, which perfectly mirrors the pathophysiology of COPD.
Right, really?
Yeah. So it raises the question, is COPD truly a distinct disease, or is it just the natural aging process of the lung violently accelerated by the oxidative stress of our modern, polluted, smoke-filled environment? Where does natural deterioration end and disease begin?
Wow. That is absolutely something to chew on during your next shift. So, take these bedside clinical reasoning skills, apply them directly to your practice, anticipate your patient's decline before it happens, and we'll see you on the next deep dive.